Nanti adik-adik sekalian akan belajar bagaimana mengenai farmakokinetik, misalkan farmakodinamik seperti apa dan seterusnya. Praktikum yang akan dilaksanakan di lab farmakologi ada 5, yaitu 1 mengenai nanti diuretik, 2 mengenai onset dan durasi obat, yang ketiga mengenai antihistamin, yang keempat mengenai analgetik, kemudian yang kelima mengenai obat-obat otonom. Dan nanti sebenarnya masih banyak materi praktikum yang bisa dilakukan, tapi karena keterbatasan waktu. Itulah sekedar pengenalan farmakologi, tapi nanti masih banyak sekali ilmu-ilmu yang dipelajari di bagian farmakologi atau lab farmakologi. Ya, demikian penjelasan singkat saya, semoga bermanfaat. Terima kasih.
Saya Aldebaran Ronaldo, angkatan 2017.
Halo semuanya, nama saya Dirgantara dari angkatan 2017. Selamat datang di lab farmakologi.
Halo, saya Ersa Nabila Maharani, biasa dipanggil Ersa. Saya dari angkatan 2017. Sampai ketemu lagi ya.
Halo semuanya, perkenalkan, nama saya Evan Japutra Sanjaya, angkatan 2017.
Nama saya Serlina Rintik Tirta Ayu, angkatan 2017.
Assalamualaikum warahmatullahi wabarakatuh. Halo Sobat Masjid Farmakologi. Sebelumnya perkenalkan kami dari Asisten Lab Farmakologi FKUNS. Jadi di sini kami ada 8 asisten. Sebelumnya perkenalkan, nama aku Utia Nabila.
Aku Aiman dan saya Yurizar.
Nah, jadi di sini kami akan menjelaskan ada topik apa saja yang akan teman-teman temukan pada praktikum farmakologi.
Nah, jadi buat kalian pasti udah sangat penasaran nih, kapan sih kita bisa ketemu di lab farmakologi? Nah, untuk di lab farmakologi sendiri, kita mengambil 5 topik praktikum. Nah, sebelumnya aku mau menjelaskan nih, pasti udah pada lihat kan buku-buku praktikum di depan ini udah cukup banyak dan warna-warni. Nah, cuma aku mau menjelaskan lagi, di sini kalau kita bakal ketemu pertama di blok 1.3 untuk praktikum konsep dan durasi, ada blok 3.2 untuk praktikum antihistamin, ada blok 4.1 untuk praktikum analgesik, dan juga ada 2 blok lagi yang terakhir, yaitu blok 5.2 untuk obat syaraf dan otonom, serta blok 6.1 nih untuk blok diuretik. Nah, pasti kalian juga penasaran ada hewan apa aja sih atau apa sih nih yang lucu-lucu di depan. Nah, silakan Mas Aiman.
Pastinya teman-teman udah kepo nih, kok di farmako nggak ketemunya obat, malah ketemunya hewan-hewan gitu. Nah, jadi di lab farmako ini, di praktikum farmakologi, kalian bakal belajar bareng nih sama 3 hewan lucu ini gitu. Dari yang paling kecil ada buncit, terus ada marmut, dan juga ada kelinci. Nah, ketemunya kapan aja? Nah, yang pertama di praktikum masuk dan durasi, kalian bakal ketemu sama marmut. Nih, kalian bakal belajar bareng sama dia. Nah, terus habis itu kalian bakal ketemu si mencit ini, si mencit yang paling kecil, itu di blok antihistamin, di praktikum antihistamin dan juga analgesik. Nah, terakhir kalian bakal ketemu yang paling besar di blok yang akhir-akhir, yaitu di blok SSO atau praktikum SSO dan juga praktikum diuretik. Nah, kalau kalian kepo-kepo juga nih masalah obat-obatannya, kita bakal ketemu lagi, bakal belajar lebih dalam lagi di praktikum farmakologi. Jadi stay tune aja sama kita gitu.
Sekian dari kami, sampai bertemu di praktikum farmakologi.
Yoi.
Fakultas Kedokteran Universitas 11 Maret merupakan salah satu fakultas kedokteran dengan program studi kedokteran akreditasi A yang berdiri di Surakarta, Jawa Tengah, Indonesia sejak 11 Maret 1976. Sebagai salah satu program studi di Fakultas Kedokteran UNS, program studi kedokteran memiliki visi untuk menjadi institusi pendidikan kedokteran bereputasi internasional, menghasilkan lulusan sarjana kedokteran yang kompeten dan unggul di bidang kedokteran komunitas. Program studi kedokteran juga memiliki beberapa misi seperti menyelenggarakan pendidikan yang berkualitas dan berstandar, riset dan pengabdian masyarakat berbasis iptek kedokteran, serta menyelenggarakan internasionalisasi program studi kedokteran.
Selama lebih dari 44 tahun, FKUNS telah banyak mengalami perubahan, baik dari segi infrastruktur maupun sistem pembelajaran. Hal ini menjadikan program studi kedokteran menjadi program studi berstandar internasional yang mengedepankan budaya luhur bangsa Indonesia.
Pengembangan proses pembelajaran di program studi kedokteran FKUNS berorientasi pada komunitas untuk mencapai profil lulusan yang telah ditetapkan, yaitu sebagai care provider, clinical decision maker, communicator, community leader, manager in health, serta researcher. Sistem pembelajaran prodi kedokteran FKUNS mengedepankan pada kompetensi lulusan yang unggul dan berbudi pekerti, serta berdaya saing global. Pembelajaran menggunakan prinsip student-centered learning melalui diskusi, keterampilan klinis, praktik laboratorium, maupun lapangan. Penyusunan kurikulum pendidikan preklinik di Fakultas Kedokteran UNS menggunakan acuan utama kurikulum berbasis kompetensi dengan sistem pembelajaran berbasis masalah atau problem-based learning. Kegiatan pembelajaran diberikan dalam bentuk tutorial, clinical skill learning, kuliah terstruktur, praktikum, field laboratory, serta self-directed learning. Program studi kedokteran FKUNS memiliki beberapa unit kegiatan mahasiswa atau UKM sebagai sarana untuk pengembangan mahasiswa dari segi non-akademis dan mengasah kemampuan soft skill serta leadership. UKM tersebut bergerak dalam berbagai bidang, mulai dari kesenian, penelitian, pertukaran mahasiswa internasional, olahraga, pers, pecinta alam, tim bantuan medis, kerohanian dan keagamaan, serta organisasi kepengurusan prodi kedokteran secara internal maupun eksternal.
Dalam 5 tahun terakhir, FKUNS terus terlibat aktif dalam penelitian kolaboratif nasional maupun internasional.
Hal ini menunjukkan bahwa program studi kedokteran FKUNS berkomitmen pada pengembangan ilmu kedokteran dan kesehatan yang tepat guna dan berorientasi pada kesehatan masyarakat dengan selalu mengedepankan pembaharuan teknologi.
Dengan budaya kerja UNS aktif, tenaga pendidik serta mahasiswa FKUNS senantiasa aktif terlibat dalam pembinaan pendidikan kedokteran dan kesehatan, pemberdayaan masyarakat, riset dan peningkatan mutu SDM yang bekerja sama dengan pemerintah daerah serta instansi luar negeri.
Demi mewujudkan iklim akademis yang dapat menunjang kompetensi lulusan, program studi kedokteran FKUNS menyediakan fasilitas pembelajaran seperti ruang tutorial, ruang clinical skills lab, laboratorium terpadu, ruang kuliah, sarana ibadah, sarana olahraga berupa lapangan basket, laboratorium CBT, kamar mandi, aula, tempat parkir yang luas, kantin yang terjaga kebersihannya, ruang UKM yang terawat, perpustakaan, ruang dosen, serta ruang pimpinan dan kaprodi yang semuanya merupakan milik sendiri. Program studi kedokteran FKUNS juga bekerja sama dengan berbagai puskesmas di wilayah Karesidenan Surakarta untuk menunjang pembelajaran field laboratory dan interprofessional education yang menjadi salah satu keunggulan pada program studi kedokteran FKUNS. Dengan komitmen dan integrasi
praktikum yang akan dilaksanakan di lab farmakologi ada 5, yaitu 1 mengenai nanti diuretik, 2 mengenai onset dan durasi obat, yang ketiga mengenai antihistamin, yang keempat mengenai analgetik, kemudian yang kelima mengenai obat-obat otonom. Dan nanti sebenarnya masih banyak materi praktikum yang bisa dilakukan, tapi karena keterbatasan waktu. Itulah sekedar pengenalan farmakologi, tapi nanti masih banyak sekali ilmu-ilmu yang dipelajari di bagian farmakologi atau lab farmakologi. Ya, demikian penjelasan singkat saya, semoga bermanfaat. Terima kasih.
Nama saya Aldebaran Lado, angkatan 2017.
Halo semuanya, nama saya Dirgantara dari angkatan 2017. Selamat datang di lab farmakologi.
Halo, saya Ersa Nabila Maharani, biasa dipanggil Ersa. Saya dari angkatan 2017. Sampai ketemu lagi ya.
Halo semuanya, perkenalkan, nama saya Evanjaptra Sanjaya, angkatan 2017.
Nama saya Serlina Rintik Tirta Ayu, angkatan 2017.
Assalamualaikum warahmatullahi wabarakatuh. Halo Sobat Masjid Farmakologi. Sebelumnya perkenalkan kami dari Asisten Lab Farmakologi FKUNS. Jadi di sini kami ada 8 asisten. Sebelumnya perkenalkan nama aku Utia Nabila.
Aku Aiman.
Dan saya Yurizar.
Nah, jadi di sini kami akan menjelaskan ada topik apa saja yang akan teman-teman temukan pada praktikum farmakologi.
Nah, jadi buat kalian pasti udah sangat penasaran nih, kapan sih kita bisa ketemu di lab farmakologi? Nah, untuk di lab farmakologi sendiri, kita mengambil 5 topik praktikum. Nah, sebelumnya aku mau menjelaskan nih, pasti udah pada lihat kan, buku-buku praktikum di depan ini udah cukup banyak dan warna-warni. Nah, cuma aku mau menjelaskan lagi, di sini kalau kita bakal ketemu pertama di blok 1.3 untuk praktikum konsep dan durasi, ada blok 3.2 untuk praktikum antihistamin, ada blok 4.1 untuk praktikum analgesik, dan juga ada 2 blok lagi yang terakhir, yaitu blok 5.2 untuk obat syaraf dan otonom, serta blok 6.1 nih untuk blok diuretik. Nah, pasti kalian juga penasaran, ada hewan apa aja sih atau apa sih nih yang lucu-lucu di depan? Nah, silakan Mas Aiman.
Pastinya teman-teman udah kepo nih, kok di farmako nggak ketemunya obat, malah ketemunya hewan-hewan gitu. Nah, jadi di lab farmako ini, di praktikum farmakologi, kalian bakal belajar bareng nih sama 3 hewan lucu ini gitu. Dari yang paling kecil ada buncit, terus ada marmut, dan juga ada kelinci. Nah, ketemunya kapan aja? Nah, yang pertama di praktikum masuk dan durasi, kalian bakal ketemu sama marmut nih. Kalian bakal belajar terus sama dia. Nah, terus habis itu kalian bakal ketemu si mencit ini, si mencit yang paling kecil, itu di blok antihistamin, di praktikum antihistamin dan juga analgesik. Nah, terakhir kalian bakal ketemu yang paling besar di blok yang akhir-akhir, yaitu di blok SSO atau praktikum SSO dan juga praktikum diuretik. Nah, kalau kalian kepo-kepo juga nih masalah obat-obatannya, kita bakal ketemu lagi, bakal belajar lebih dalam lagi di praktikum farmakologi. Jadi stay tune aja sama kita gitu.
Sekian dari kami, sampai bertemu di praktikum farmakologi.
Yoi.
Selamat datang Prof. Revi.
Ya, selamat datang.
Program studi kedokteran juga memiliki beberapa misi seperti menyelenggarakan pendidikan yang berkualitas dan berstandar, riset dan pengabdian masyarakat berbasis iptek kedokteran, serta menyelenggarakan internasionalisasi program studi kedokteran.
Selama lebih dari 44 tahun,
Good morning.
Hello, good morning.
FKUNS telah banyak mengalami perubahan, baik dari hal ini menjadikan program studi kedokteran menjadi program studi berstandar internasional.
Dr. Latif, can you hear me?
Yes.
Yes. Good morning everybody. Good morning Prof. Rupaipun. Good morning Prof. Reviono. Selamat pagi teman-teman semua. Assalamualaikum warahmatullahi wabarakatuh. Selamat datang pada acara International Guest Lecture pada hari ini, Sabtu 16 Oktober 2021 dengan topik Economic Impact of Covid-19 and Vaccination. Yang pertama adalah akan kami bacakan susunan acaranya. Yang pertama adalah pemutaran lagu Indonesia Raya National Anthem, and then at 9:30 opening by the Dean of Faculty of Medicine Universitas 11 Maret oleh Prof. Reviono, dokter spesialis paru konsultan, and then 9:40 introduction by reading CV, and then 9:45 guest lecture session for 1 hour, and then discussion for about 15 minutes. And the first time is Indonesia Raya National Anthem. Okay. Okay. And then the opening by the Dean of Faculty of Medicine Universitas 11 Maret, Prof. Dr. Reviana, spesialis paru konsultan. Dipersilahkan. The time is yours.
Okay, thank you. Good morning, ladies and gentlemen. Welcome to this international webinar. And today the title is Economic Impact of the COVID-19 and Vaccination, held by Universitas 11 Maret in collaboration with Mahidol University, Thailand. As the Dean of Faculty of Medicine at UNS, I'm feeling grateful and enthusiastic for this occasion, and I'm sending my appreciation to Professor Arthon Rui Paipon, MS, PhD, MSc, PhD, as key speaker. Good morning, Prof. Arthon. And also to Dr. Hafida, PhD, and Dr. Ratih Puspita, PhD, as moderator, and MC to all of colleges from Department of Pharmacology who have organized this event, and to all joining participants for today's webinar. It's been nearly 2 years since COVID-19 first emerged, and the virus and disease are sadly still with us globally until today. Despite the current decreasing rate of active cases and fatality, the initial surge last year and the following Delta variant outbreak few months ago clearly have devastating impact on many aspects. During that dark period, we repeatedly heard and saw many families losing their loved ones to COVID-19, while some survivors experiencing long COVID. In many settings, students still have to study remotely, workers having to lose their income to some degree, people to refrain from meeting each other, and government around the globe struggling to finance the health. Also, societal and economic impact of the pandemic with health system were even collapsed in some countries during the surge. The positive side is the continuing pandemic has led to biomedical breakthrough with development and deployment of COVID-19 vaccines at the pace we've never seen before. We are currently witnessing the overall lower incidence and fatality rates of COVID-19 than before, thanks to the vaccines. And yet, vaccine is not a silver bullet, and some experts warn the possibility of the recurring surge in early next year. Some barriers also remain, where some people are still having a distrust issue toward the pandemic staff, or are simply tired of the unending pandemic, leading to low compliance with implement measures to prevent the spread of the virus, individual reluctance, fearing of the vaccines adverse effects, geographical constraint for equitable vaccination program, the fading protective effect of the vaccines, and the emergence of new variants just add the problem. These public health challenges need to be addressed from multifaceted perspective, and health economics is offering the tool to estimate such disease burden, as well as effectiveness or treatment or intervention and their impact. We are fortunate that we have Professor Arton with us today, who is going to kindly share his knowledge and expertise on pharmacoeconomics to address COVID-19 and its vaccination. We hope this great initiative will continue in the near future in the form of either teaching or research collaboration between the two universities. All right, I don't want to hold you up from the main agenda with my long speech. Thank you for your attention and enjoy the webinar. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Prof. Reviono. And next is the main agenda. Will be guided by Dr. Nur Hafida Hikmayani. Dr. Hafida is graduated from the Pharmacoepidemiology and Clean Epic from the University of Newcastle, Australia, and she got her PhD in informatics at 2020 at University College London, UK. Dr. Nur Hafida Hikmayani, the time is yours.
Okay, I just want to check for a second. Can everyone hear me clearly?
Yes, clear.
Okay, great. Okay, thank you very much, Dr. Ratih, for the kind introduction. And good morning, everyone. I'm Hafida from Department of Pharmacology, Faculty of Medicine, Smart University, assigned as the moderator for today's international guest lecture. Just before we start, allow me to read out some basic rules for this session for a seamless lecture, of course. I know it's a cliche for we all get used to webinar during the pandemic, but anyway, here they are. Just give me a second for a shared screen. Yeah, well, basically we got only 3 rules. First, as usual, please kindly mute your microphone throughout the session. But you can always type in your question either in Bahasa or English on the chat column. Otherwise, if you want to ask directly, please wait until the lecture finishes and you can raise your hand and ask your question in English. We got an extra here. At the end of this event, we're going to pick 3 participants who we think have submitted the best question. So stay tuned. Well, that's all for the rules. I think the slide is not synchronous to what my talk. Okay. And now I would like to introduce our speaker, Professor Arthur Paipon. I hope I pronounced it correctly. Well, actually, it's my first time to meet Professor Arthur, and it's virtually. So my hello to you and my good morning to you. And welcome again, Professor Arthur. We are very privileged to have you here today. I hope the weather in Bangkok is lovely this morning because it's a pretty sunny day here. So if you don't mind, I will briefly, we got a display here, a summary of your CV. So I will read it out before you give your lecture, if that's okay. Dr. Arthur is a professor of pharmacoeconomics from Department of Pharmacy, Faculty of Pharmacy, Mahidol University in Bangkok, Thailand. He completed his bachelor and master's degrees from Thailand and obtained his PhD from Curtin University of Technology in Western Australia. His main interests are for health economic evaluation, hospital cost analysis, and healthcare program cost analysis, focusing on vaccination for non-communicable diseases. Professor Arthur has impressive professional experiences here. He's been serving as consultant for WHO and International Vaccine Institute. He also served as editorial board for 2 leading journals and has led many health economics research funded mostly by the Thai government. He has authored a book titled Measurement of Cost. Okay, that's all. So now we can start our main agenda, which I think everyone has been waiting for excitedly, which is the lecture from Professor Arthur about the economic impact of COVID-19 and vaccination. Please, Professor Arthur, the next 1 hour is yours.
Thank you, Dr. Hafida. Can you hear me?
Yes, very clearly.
Clearly, okay, thank you. So thank you, the university, for inviting me. Let me share screen because the time is limited.
Very busy person.
Okay. Okay. Do you see the slide?
Yeah.
Okay. Okay. Again, thank you very much for the university for inviting me to give the lecture for today. First of all, I would like to say Selamat pagi, Batak dan Ibu. That means the สวัสดีครับทุกท่าน in Thai.
Selamat pagi, Professor Arthur.
Okay. So the objective of this lecture that I would like you to understand the overview of health economics or pharmacoeconomics that related to the pandemic, COVID-19 pandemic. And also right now there are many papers related to economics of the COVID-19 pandemic. I would like you to familiar with those articles. That 2 objectives for today. And to achieve that objective, I would like to cover the what is the difference between macroeconomics and microeconomics impact, and also focusing on the microeconomics. Include the cost of unit study, cost of public health intervention, cost of medical services, and also the economic relation of the health interventions. Okay. Starting with the situation. Okay, this is just last week. The cumulative numbers of the COVID-19. You see that globally it's nearly 240 million confirmed cases, and the number of deaths is nearly 5 million right now. And when we compare the regions, the Southeast Asian, the 3rd rank. And if we consider the statistic just 2 weeks ago, this is the weekly statistic. Now you see that the Southeast Asian it come up to be the 2nd rank after the America. Yeah. And the proportion of the cases is similar to the proportion of the population, because America is approximately 1 million population. For Southeast Asia is around 7 million population. And now, if we see the impacts to the country economies, okay, as Professor Leviono that already mentioned that COVID-19 had effect a lot on our country economies. So let's see what kinds of information when we expect the effect on the country economy. Okay. I give you an example. The study compare the effect on economy in Asia and in Europe. Okay. This paper mentioned that in terms of GDP or gross domestic product, that's it, key indicators of the economy situation. Okay. It stated that in China, when consider the GDP in the year 20 and 20, okay, comparing to the previous periods, so the economy is shrinking by 3.8%. The South Korea is a little bit better because it's just around 1.2%. But when compared to Europe, France is quite serious because the effect around 33% of economic activity that decreased comparing to the previous year. Okay, and also the consumption of the people decreased by 32%. In Germany, it's a little bit better than in France, like South Korea better than China because in Korea it allows 6%, but still similar to the China. That effect on the economy. In Spain, the study in Spain mentioned that when we consider the effect on the macroeconomics, so we consider the GDP, that the key indicator of economy, and also consider the production level that include the supply and demand in the market. Okay, the indicators that they use to indicate the level of production or the supply and demand, they measure in terms of industrial production index, business turnover index, and consumer confidence index, and also consider the effect on the labor market in terms of the unemployment rate that increased during this period. And this paper also indicate the effects of the number of cases that affect on the GDP of each country. Okay, this is the level of the GDP growth. Most of them is have a negative effect, is minus or negative effect on the GDP. That means the growth is decreased, not there is no growth. We call the shrinking economy. Okay, and this is level of the GDP, and this is the total confirmed cases of death, okay, per million. You will see that the higher number of deaths, okay, had more effect on the GDP. Okay, it's clearly that the COVID-19 effect on the economy of the country. Okay. And focusing on the regions, Southeast Asia regions. Okay, this is the paper from the World Bank just last week. Okay. Also showing the GDP growth this year. They compare the Q1, the first 3 months, and second 3 months for Q2 this year. Okay. This is level of growth as well. There's a negative effect, the positive effect. That's there is growth here, shrinking here. Okay, and you will see that they compare the effect of each country by comparing to the level of vaccination, in terms of the coverage of the first dose, at least first dose of the vaccination. This is also clearly had a positive effect. Okay, previous slide showed that a negative effect of the cases of the death. Okay, this is positive when we compare the level of the coverage of the vaccination. So the higher vaccination is a better economy. Okay. We have talked a lot about the GDP or gross domestic product. This is the economics. Okay. In the simple way to define the terms, we can say that the GDP is the aggregate measure of the production in the country. Okay. To produce goods, to produce the service, like in tourism industry, it's also part of production, but the service production. Okay, and the goods that we produce and consume and export, and also the part of production. Okay, and another way it related to the the sum of the goods and service that we produce. but we have to minus the goods and service that we import, because this is the domestic. That means what happened to the inside the country. So we exclude the goods and service that we import into the country, just what we produce in the country. This is the simple definition of the GDP. Okay, and if you interested in this area, you would like to see in more detail, you can go to the website of the World Bank. Okay, they provide the data year by year and by country. Okay, you will see that before the year 2000, the level of GDP Thailand and Indonesia were very similar. Okay, after that, it's much better in Indonesia. Yeah, higher, nearly right now it's double. Like in Thailand, it's around 0.5 trillion, half of the Indonesia. It's around 1 trillion. Trillion, that's million of million. Okay, it's quite big economy. Okay, that's about the country level, the economy of the country level. Now focusing on the health system of the country. What happened to the health system of each country? Okay, this is an example of the study from Iran. Okay, they show the effect of the COVID-19 on the direct medical cost and indirect cost. Okay, direct medical cost is like a treatment cost, the healthcare cost. Okay, covering like intensive care, physician visit at OPD, surgeon, nursing service, drug, rehabilitation, investigation. This is what we familiar because it's related to the treatment in the health facility. Okay. This is what we call indirect cost. Okay, indirect cost is the cost of the productivity loss of the people who get sick. Okay, I'm going to explain more detail later. Okay, but now you can see that when we consider how big of the burden of the disease to the people, if you see this is the average treatment cost or average direct medical cost per episode. That means per person per time of the infection. Okay, it's nearly $4,000 per episode of the COVID-19. Okay, and if you see when include the indirect cost or the time loss of the patient, so it increased to nearly 12,000 per episode. Okay, and compare to see how big of the burden. So we compare to the GDP per capita. Okay. It's similar to like a total income per person per year of the people. Okay, similar to that meaning, but not exactly the same because GDP they calculate a different way, not just the total income. Okay, but the meaning is quite similar. When we compare to the GDP per capita per year, okay, you see that this is less than just $1,114 per person per year. But this is just one episode is more than the income per person per year. Okay, you see that how serious of the economic burden of the disease. Okay, for the indirect cost, or we may call productivity loss. Okay, there are two parts when we calculate the productivity loss. It's related to the time loss of the patients. Okay, the first part of the time loss is when patient gets sick. Okay, they cannot work. We call the job absenteeism. Okay, in this study, they estimate during hospitalization, it takes 7 days. Okay, and after that recovery period at home, another 21 days. Okay, multiplied by the minimum daily income to be the total cost for the job absenteeism. Okay, and as you know that there are a lot of deaths from the COVID-19. So in this case, the average time loss. That means when they compare the average age of the people when they dead compared to the retirement age. Okay, that means if they don't die, they keep working until retire age. Okay. So in this case, the average year loss of the COVID-19 patients is 11 years. Okay, they convert the future income during 11 years and sum up to be the total indirect cost that we call the premature death. Okay, that caused by the premature death. Okay. So in this case, this is the future. Okay, this event happen in the future. Okay, if they don't die right now, they keep working in the future for 11 years. So when we estimate the cost or the loss of the future income, so first we have to estimate the future income. This is okay. So in this study, they have the minimum income at the study year, and they forecast the future income by using the 3% growth during 11 years in the future. Okay, and after that, we cannot make a simple summation of 11 years because this is income in the future. The value of the future money and the present times are not the same. So in economics, not the same. So you cannot just simple summation. In economics, we have to do what we call discount. That means we discount the value of the future into the present time. Okay, they use a 6% discount, and after that, make a summation to be the total indirect cost from the death per case. Based on the burden that we have discussed, so we have to face the problem. Okay, we have to think how to tackle the problem, that this health problem. Okay, at the global level, the WHO the WHO at the leader, okay, create a lot of intervention to tackle the COVID-19 problem. So like this is the data in in this current year, in the year 2021. Okay, the WHO proposed so many interventions. Okay, to tackle the COVID-19 problem. So in summation of all of these activities, we can summarize into the program management activities or the program support activities, okay. The disease prevention and control activities for the disease care management, including the treatment. And the last one is research and development innovation, like we try to have the better and better vaccines and also drug related to the R&D. Okay. All of this for 1 year that the WHO proposed it nearly 2,000 million US dollar. Okay, that the WHO estimate to use for this year. And previously, you will see that there are many types of the intervention or measure to solve the COVID or to decrease the COVID-19 problem. Okay, in this case, when we have a different intervention, okay, so each intervention, there are different costs of each intervention, and similarly, they also provide the different outcomes. So in the public health management, when we face the problem that we have many choice of intervention with different costs and different outcomes. Okay, in this case, when we have to make decision to choose which one, okay, we need to apply the economic relation method, that part of health economics. Okay, that means we have to combine the cost and outcome together to be one number, and then we can compare. Okay, like this study in UK. Okay, the intervention composed of the mitigation that include individual case isolation, home quarantine, and social distancing for the people aged more than 70 years. Okay. And another one they call subpatient. Okay, subpatient include a general social distancing. Okay, that everybody, not just all elderly people. Okay, and also the disclosed school and university. Okay, this is more serious than the mitigation. Okay, and then they compare two measures. Okay, and the result to have the number of cases and the number of deaths as the outcomes of intervention. And in health economics, we combine the outcomes in terms of number of cases and number of deaths into the what we call the quality adjusted life years. Yeah, yeah. Then the analysis it come into the cost per additional quality adjusted life year. Okay, when compare the two interventions like this. Okay, and the result for this study in the UK, just summarize for you that okay, when we conduct the equilibration and using cost utility analysis, okay, we got the cost per quality like this. We have to compare what we call the threshold or the benchmark of the country. Okay, in the UK, they use the 50,000 per quality as a threshold. That means if the interventions that we propose, okay, have the result per quality here less than the threshold here, that means we say that they are cost effective, and normally we accept that for the implementation. Okay, this is the equation of the different intervention for the COVID-19 pandemic. Okay, and this is another study in Taiwan. Okay, focusing on the vaccine. Okay, Moderna, Pfizer, Astra. Okay, and comparing to without the vaccine. Okay, similar to the previous one. Okay, they conduct cost utility analysis. Okay, and again they calculate the cost per, in this case it QALD, quality adjusted life day. Okay, previously it's a number of time in years. This study they use the number of unit of time in day, quality adjusted life day. Okay, and this is a negative. That means the intervention provides saving. Okay, we don't lose when we implement, we gain. Okay, we call the dominant, comparing to no vaccine. Okay, that means if we use the vaccine, we can make a saving. Okay, we can have the more study to make the clear result. We can apply the cost benefit analysis. So in this case, the net benefit that focusing on the saving from the vaccine implementation, okay, is a positive number. That means the vaccine intervention produce the saving to the health system. Okay, so in conclusion, it confirms, provide evidence quantitatively. Okay, because normally we accept that we need vaccine because the vaccine can prevent the disease. Okay, but how much? Okay, this kind of study can provide the evidence quantitatively that how much the vaccine can provide the result to the health system in terms of the both the clinical outcomes and the economic outcomes. This slide led to see in more detail of the costing part of the study. Okay, in the detail of the costing part of the vaccine study. Okay, the part of direct cost. Okay, mainly is about the treatment. Okay, like a confirmatory diagnosis, about the investigation, about the treatment here. And part of the direct medical cost, we can see that this is the cost of the intervention or cost of the vaccination program. Okay. It composed of the cost of the vaccine and cost of the administration activities. Like we manage to have the the walk-in area for the people who come to get the vaccine. Okay, we need a special place, special management, okay, to provide the vaccine. Okay, this is the vaccine administration cost. Okay. And this study includes the indirect cost of the patient as well. Okay, that means if the people who do not get the vaccine, they get the illness, okay, or even the group that receive the vaccine, okay, some of them also get the illness, okay, because the vaccine is not 100% efficacy, okay, even a vaccinated person still have infection, okay, and when they get the infection, they have the illness, okay, this is a time loss of the patient, similar to previous study, okay, they convert the day lost during hospitalization, okay, and also the people who get the vaccine, okay, because the time loss it happen to both groups. The group that who come to get the vaccine, okay, when they come to get the vaccine, they have to leave from their job, their work, okay, estimate half day for coming to get the vaccine, okay, this is time loss of the vaccine program, okay, including time loss due to the adverse effect of the vaccine, okay, estimate 2 days. Another part of the time loss is the hospitalization in the group of the people who get the infection of the COVID-19. Okay. You see that at the moment, there are many articles, many reports that related to the impact of the COVID-19. Okay. We can see that some papers mentioned on the macroeconomic levels, some papers mentioned on the microeconomic levels or cost of illness. Okay. How can we understand this kind of academic articles? Okay. Even we are not health economists. Okay. We are clinicians. Okay. We still need to understand this kind of the study at some level. Okay. I don't think that you need to understand everything in the papers. Okay, that you need to study health economics, then you can understand everything. But as clinicians or practitioners, clinical practitioners, okay, you are part of the public health system. You need to follow the public health policy. Okay, you should understand at some level of the policy. Normally, the policy decision is based on not only the clinical aspect right now, not only in the epidemiological aspect right now, but the health economic aspect is also part of the input for the public health decision making. Okay, and you as a clinicians or practitioner should understand health economics at some levels. So I would like to introduce some overview of the health economics related to the COVID-19. When we consider the cost associated with the COVID-19 pandemic, so we can classify into basically it's a financial outlay or the simple cost or expenditure when we pay for the activities, when we buy some medicine. Okay, this is a financial outlay. It's simple thing. Okay, but in addition to the financial outlays or financial costs, okay, we have to consider opportunity cost. Okay, especially like for the COVID-19, you will see that there are so many organizations, there are so many volunteers to help to tackle COVID-19, like a screening, like many mitigation activities, many volunteers from non-health sector. Okay, those costs that we include into the consideration of the COVID-19, we call the opportunity cost of those volunteers. As I mentioned earlier, that we can classify into macroeconomic impact and microeconomic impact. For the macroeconomics, okay, it related to the demand supply in the economy, related to the unemployment, related to the productivities that cover import and export goods. Okay, and in some, okay, we present in terms of the GDP, gross domestic product. Okay, and for the microeconomics impact, okay, we focus on what we call cost of units. Okay, cost of units that borne by the individual or households, that affect on the firms or business, effect on the establishment like school, hospital, clinic, health center, and then effect on the government as a whole. Okay. Now, I would like to show you the health intervention and health mix aspect. In this, I can show you that right now we have the people, both still healthy and at least of the COVID-19. For example, like people who have the chronic illness, who are elderly, okay, pregnant, okay, that people at risk of the COVID-19. Okay, how can we manage these people? Okay, for the healthy people, we still would like them to keep healthy by provide health promotions like exercise, something like this. Okay, and the people at risk, okay, we provide the disease prevention and control. And when we provide the intervention, either health prevention or health promotion, okay, we have to set the outcome of the program. Okay, for the health promotion, we just would like to change the behavior, to keep the good behavior, to be still healthy. Okay, then we set the goal of the program, and we said, okay, what case is success, what case it fail. That's the outcome of the intervention. Okay. But in case of the way we provide prevention, the outcomes that we expect is to avoid the number of cases. For the screening, okay, we provide the ATK to detect the case, or we provide the PCR to detect the case. Okay, this is also the prevention. Okay, to detect the case for the screening. And for the control, okay, we measure in terms of the case avoided, like we provide the social distancing. After that, how many cases that decrease or case avoided. Okay, this is outcome of the intervention. Okay. And all intervention is not 100% effective. Okay, in this case, that means even we provide the intervention, we still have the case of the infection of the patient. So okay. When we get the case of the infection, we have to provide the clinical intervention. Okay. For example, we provide the medicine. Okay. We also cover the way to manage the case, like we have the home isolation, we have the field hospital. That's also part of the clinical intervention. And the outcomes of the critical intervention, okay, we measure case averted, how many cases can kill, or the success case in terms of the chronic illness, it might not kill. So we set the goal of the treatment and we said, okay, this is the success case, the failed case. Okay. And we can measure the outcomes in terms of the life year gain. If we prevent death, okay, how many years that we can save for the patients. Okay. And also we measure in terms of death averted as well. Okay. And when we want to combine the result in terms of number of cases averted and number of deaths averted into one indicator, okay, we convert both of them into the quality adjusted life year. Okay, this is part of the quality of life. Okay, that I mentioned earlier that in cost utility analysis, we measure the outcome in terms of the quality. Okay, or sometimes they measure in terms of DALY. Okay, DALY is a disability adjusted life year. Okay, similar to the quality. Okay. Now, in each intervention, okay, previously I talked about the outcomes of the intervention. Okay, now we consider the cost, the part of the cost. Okay, the health promotion, disease prevention. Okay, we may call the public health intervention. Okay, we have to measure the cost of the intervention. Okay, and when we get the case of the illness and provide the treatment, okay, we convert the cost of the treatment that provided by hospital and the cost that happened to the patients, yeah, and sum up to be what we call the cost of illness. Okay, and in the part of the cost of illness study, okay, we need to know the cost of the medical service in the hospital. Okay. When we provide the clinical intervention, we need the unit cost of this kind of intervention that we call the cost of medical services that we have to analyze in the health facility when we calculate the cost of illness. Okay. And this is the diagram to show that when we have the different interventions, we have the choices of intervention. Okay, we have to compare to select the best one. So we have to compare both cost and outcome. So if we compare the outcomes related to the clinical outcome here, compared to the cost, we call the cost effectiveness analysis. And if we compare the cost of intervention to the quality of life outcome, or we may call the humanistic outcome, in terms of the quality, in terms of DALY. Okay, in this kind of study, we call the cost utility analysis. Okay, and if we convert the result of the illness in terms of the saving or the change or the cost of illness, that means we convert the result here in terms of the monetary unit. Okay, we call the cost benefit analysis here, CBA here. And we also compare the result of the health promotion at this level, okay, in terms of number of success cases. Like we provide the education, health education, and we measure the score of the knowledge, and we set the cut point to be success or fail. In this case, we can count number of success cases who pass the score. Okay. And in this case, we can conduct the cost effectiveness of the health promotion intervention. Okay, now a little bit more academic aspect. Okay. We talk about the cost many times. So what is the official definition of the cost? Okay, The official definition of the cost means the cost of the goods or services. It's when you of the resources consumed to produce goods and services. Okay? Like your services in the hospital is the OPD case. Okay? You provide the treatment for the outpatient case. Okay? When the patient get the treatment, okay, that the service that you provide to the patients. Okay? To provide the service at the outpatient service to the patient, so you need the labor. Okay? You need the time of the doctor, nurse, and supporting staff. Okay? You need the room of the building. You need equipment. Okay? You need the medicine. You need the chemical reagent for the lab test. Those are resources that you need to produce the service for the outpatients. Okay? You have to convert those of the resources to be the monetary unit that we call the cost. Okay? And based on this definition, okay, it includes something that you haven't paid to have that. Okay, I'm going to talk later about the opportunity cost. Okay, and the example here to let you know here that sometimes at the OPD outpatient department there are volunteers to facilitate the patients. Okay, that's those kind of labor. They are volunteer. Okay, you don't pay the salary for them. Okay, but those labor times are resources that we consume to produce the service. So, we also have to include the time of the volunteer to be part of the cost as well. Yeah. Based on the general, the basic definition there, okay, we can classify into the economic cost. Okay, the economic cost is the include everything that I mentioned, that not just the resources that we pay the money to get the resources, but including what we get free of charge for donation, for volunteer. We also have to include in terms of we measure the economic cost. But the financial cost is simple in daily life. If we pay, there's a cost. If we don't pay for that, there is no cost. That's a financial cost. So as I mentioned earlier, that in economics, including the volunteer, the donation of the material, so we have to include into economic cost, because they have the what we call opportunity cost. That means if we don't use the volunteer time, the volunteer gonna use their time for the other kinds of the production. Okay. If we don't receive the donated drug, okay, for our hospital, those drugs gonna be used for the other hospital. Okay. That means they have the choice, opportunity to use those resources. So in this case, we call the opportunity cost. Okay. When we convert donated cost of the cost of the donated goods. Okay, we use the market price. Okay, and when we convert the volunteer times, so we use the reference or the base payment of those volunteers. Okay, if they don't work for us, okay, they work for the others, how much they can get payment, and we use those amount for our calculation. Okay. In addition to the economic cost and financial cost, okay, there is another type of cost that we know already in terms of the budget. Okay. But when you read the economics paper, sometimes they use the term fiscal cost. Okay. We use the term fiscal cost for the budget planning. That means we would like to estimate how much we are going to pay for now and for the future. Okay, so the meaning is the same as the budget. Okay. The definition of fiscal cost is straightforward. It equal to the financial cost. But the difference is that when we consider the cost of the equipment, Okay. In terms of financial cost, we have to calculate what we call depreciation cost. That means we divide the total cost of the equipment year by year during the time that you use the equipment, or we call the useful years. Okay. But when we calculate the cost of that equipment in terms of the physical cost, okay, you just calculate the total purchasing cost in the year that you purchase or you buy the equipment. Okay, you don't need to convert by dividing the cost per year during the time of using the equipment. Okay. This is the different point of cost equation between the financial cost and physical cost. Another term that you may see in the papers, they use the term the full cost and incremental cost when they estimate the cost of the program. The full cost is everything that used for the program. For example, your hospital implement the COVID-19 program. Okay, the staff of the hospital allocate their working time, like they spend 1 day a week for the COVID-19 program. Okay. When we calculate the full cost of the program, so we have to allocate the salary of the staff equal to the time that they work for the program. Okay. Even the program doesn't pay the salary to the staff because the staff already get the salary from the hospital. Okay. Just when there is a COVID-19, they have to help the program. So they allocate their time to the program. So we have to estimate the salary equal to the working time that work for the COVID-19 program. Okay. In this case, we call the full cost. That means we cover everything, every kind of resources that used for the program. Okay. But if we say that, okay, this program just cover the incremental cost of the program. Okay. In this case, we consider that if there is no program, there is no cost. But if the cost happen because of the program, that means those costs happen because of the program. So, for example, in this case, if we consider the incremental of the program, okay, we don't include the salary of the permanent staff. Okay, we just cover the per diem when the staff work for the program pay the per diem for the staff. Or the per diem is incremental cost of the program. Or the program hire the additional staff and work full time for the program because the staff of the hospital is not enough. So the program have to hire additional staff work full time for the program. So the total salary of additional staff to the program are part of incremental cost of the program. Okay, these are different between the full cost and incremental cost. Okay. So we have to be careful when we read the paper, and we try to compare the cost of the program from different studies. Okay. Make it clear that in each study they define the full cost or they define the incremental cost, because it can be possible of both type of the cost. It's up to the objective of the study. It can be full cost, it can be incremental cost. A little bit more detail of the type of the cost to be more understandable when you read the papers. Okay. There are many types of the classification of the cost or the inputs to the program. Okay. One of the popular classification is to classify into the capital cost and recurring cost. Okay, the meaning of capital cost is the items other input or resources that you can use for longer than 1 year. Like you have building, you can use for 20 years, 30 years. That more than 1 year. Okay. We have computer, you can use 2 years, 3 years, 4 years, 5 years. That more than 1 year. Okay. You have the machine that used for many years. Okay. Those are capital items, or when we calculate, we call the capital cost. Okay. We need to know how long that we can estimate for using those items. And we simple divide. The basic idea is to divide the cost when we purchase those items along the period of using. Normally, we can get cost per year during the time of using those capital items. The second group we call the recurring cost that use up in opposite to capital cost, the item that we can use in a short time, okay, finish in 1 year. Yeah. We may call the running cost or operational cost, like the labor or the material. This is an example of the capital cost. As I mentioned earlier, purchase equipment, vehicle, lab equipment, other equipments, building. Okay, and I would like to explain more for this one. We call the investment cost. Investment cost. Okay. We also classify as the capital cost as well. What I mean investment cost, like you provide the education or the training. Okay, the knowledge that you can have from the education and the training. Okay, you can use the knowledge for your work for many years. Okay, or you provide the social mobilization, you provide the campaign to change the behavior of the people. Okay, and once you change the behavior by providing the social mobilization, the people can keep behavior like that for a few years, for more than 1 year. Okay, that means the intervention on the country building, on the training, on the campaign, okay, had effect. You can use the effect for more than 1 year. Okay, this is why we classify this kind of activity as a capital cost. Okay, so the calculation is similar to the how to calculate the cost of the equipment. So we need to know the total cost of the whole activities, the whole program of education, the whole program of the campaign, and then you have to estimate how long that you can use the knowledge, and then use the same formula for the calculation. Yeah, and for the vaccine, okay, we usually have this kind of the capital cost. Okay, because when we introduce a new vaccine, okay, like a COVID-19 vaccine, okay, at the early phase, so many people reluctant to get a vaccine because of the adverse event, because of not sure. Okay, and especially for the Muslim people, like now, we have a big challenge in the southern part of Thailand that most of the people are Muslim. Okay, they're reluctant to receive the vaccine. Okay, we have to put a lot of social mobilization or campaign. Okay, to change the attitude and behavior of the people. That when we calculate the cost of the program, okay, we calculate like a cost per year. Okay, we don't put the total cost of the campaign in the year that we implement the program. So we have to calculate the cost per year by divided the total cost of the campaign into the periods that we expect that the campaign can have effect on the people. Yeah. That is specific to the vaccination program. And for the labor cost, okay, for the labor cost is including the paid labor, including volunteer, per diem, travel allowance, and the material cost cover medicine, vaccine, transportation, maintenance, co-share like this. Okay. Another point that I would like to emphasize, we call the perspective. Okay. When you read the papers about the costing, about the equation that include the cost, you have to be careful and focus on the perspective of the study. Okay, when you read the paper, looking for the term perspective or the viewpoint in the paper, and see what perspective that defined in the study. Because the same events, like there is one illness, the patient get treatment, okay, in the same illness, the same treatment, okay. And when we consider the cost of the treatment, okay, we have to consider the cost of the treatment from what perspective, okay? Because the same events, the same treatment, different perspective are different number of the cost. The value of the cost are different based on the different perspective. Okay? We can classify the perspective into the patient perspective, like the treatment, the patient under the UC, the patient doesn't pay for the treatment. That means the treatment cost for the patient perspective is zero, no cost. But the hospital still have cost. Okay, you see. And for the health promotion, disease prevention, I use the term service receiver and beneficiary, like people who come to get a vaccine. They are not patients. Okay. Like for the vaccination program, when we consider the cost, okay, we don't say that we calculate the patient perspective, but we calculate in the service receiver or vaccine receiver perspective. Okay. Previous article that mentioned that the patient who come to get a vaccine, okay, have the indirect cost on the time lost when they come to get the vaccine. Okay, this is a cost of the people who receive the service. Okay, but the time cost of the patient or service receiver not part of the hospital. Okay. And when we consider the broader perspective, like for the COVID-19, okay, not only the treatment of the hospital, so many stakeholders at the so many departments, okay, involved. So in this case, we have to cover all of stakeholders who participate in the program. Okay, so we call the health system perspective. And broader than that, like for the COVID-19, not only Ministry of Health that involved, the police, the soldier, Ministry of Interior also participate the program. So in this case, we may call the public sector perspective. And if we consider the payers, like in Thailand, the National Health Security Office is a payer or insurer. Okay, they provide the compensation for the people who come to get the vaccine and have the side effect or death. Okay, the amount of money that paid by the insurers for the one who get the vaccine and have the side effect. Okay, this is the cost of the payers, not of the hospital, because the hospital doesn't pay those, but the insurance pay for that one. Okay, and finally, when we try to cover all in the society, patient and provider, okay, sometimes include into the health system, health sector, we cover all of this. We call the social perspective. Okay, that's the broadest one. We call the cost from the social perspective. Okay, mainly cover the the patient or the one who received the service and the provider together to be the sort of perspective. So in the detail, when we consider, we have to be careful what we call the double counting, like the patient pay for the treatment in case they pay for the treatment, the payment and the cost of the providing the service. Okay, we cannot add both of them together. We call the double counting. So that just less the point. Okay, I don't have enough time to explain more. Just less the point that have to be careful. The point of we call the double counting when we consider the total cost. Now come to the concept. When we would like to calculate the cost, okay, the simple formula is the cost equal to the price of the resources multiplied by the quantity used. And sometimes when we have the share cost, like the person who work for many activities, when we would like to calculate the cost per one activity, as I mentioned that the staff who work one day for the COVID-19, okay, that means if we can the cost of the COVID-19 program, we have to adjust one day of the working time for the COVID-19, not the total salary. Okay, that's a one day in a week that 20% of the salary that we allocate to the program. Okay, and in the detail, we classify into the 3 steps. The first, we identify the resources that we use. Okay. Based on the category of the cost. Okay, we have to define what component that we are going to include in our study. Okay. We don't need to cover everything. Okay, based on the objectives, we can classify. Sometimes we just include the material and the labor cost. We don't include the equipment cost. It's possible enough to the objective. So, but we have to make it clear when we design the study that, okay, what kind of resources that are going to be included in our study. Okay? And then we measure each of them, the quantity of use of resources used for the production or the service. And after that, we convert the quantity of each item into the value. Okay, in this case, we need to know the unit price or the cost. Like, okay, we know the number of staff. We need to know how much per day, how much per month. This is the unit cost of the labor. Okay, we know that we use how many doses of the vaccine. Okay, here, in this step, we need to know how much per dose, and then we convert into the cost of the vaccine, cost of the labor. Now, moving to the one of the key content. Okay, I call the cost of units. Okay, the cost of unit defined as the total economic impact or cost of the disease or health condition on the society. Okay? In general, we define on the society, but in practice, we may use in the other perspective. Okay, the cost include both direct and indirect costs. As I mentioned in the paper, direct cost, indirect cost is like a time cost of the patients and caregivers. Okay. When we define the disease to be studied, okay, we have to define clearly what is the disease. Like when we talk about the seasonal influenza, we have to define it include ILI, include SARS, okay, clearly to include in the seasonal variation. And what is the primary symptom of the disease? Okay. And when we calculate the cost for the treatment of primary symptom, and also the cost of the complication as well, but not include the comorbidity. Okay. This is the definition of the cost of illness. And when we consider the cost of illness, when you read the paper, it's also important, similar to the perspective. You have to see the study that they conduct based on the prevalence or incident-based approach. Okay, to be easier, okay, I show the diagram like this. Okay, In this case, the line is represent the period of the episode of the disease. Okay, it's a time period of the episode of the disease. When we design the study, so we have to decide the period, like a 1 year of the study, 1 year of the study. Okay, and when you review medical record of the patients. Okay, the patient might have the disease before the starting period. Okay, and finish the episode here. Okay. If you decide to study prevalence, you just include all patients that you find in this period. Okay, from this is the study period. Okay, you include every patient in these two lines. Okay, and also include the cost that happen in these two lines only, not before, not after. This is we call the prevalence based approach. But if the study use the incident based approach, okay, you just include the case, the new case. Okay, new case, not include this one. Okay, just this one because a new case in the period. Okay, new case, this new case, this new case. Okay, but when you include the new case, you have to follow until finish the episode. Until finish the episode. Okay, this is the meaning of incident based approach. Okay, this is for the acute because the episode is not so long. Okay, but for the chronic one, okay, the chronic one is like a forever until death. Okay. The same concept. Okay, the same concept. But in practice, for the chronic one, you have to follow. For the incident, okay, for the prevalence, it's no problem because you have clearly point to include. But for the incident, you have to follow the new case until death. Okay, so we may call the lifetime cost. Okay, lifetime cost because we have to follow until the whole lifetime of the patients. Okay. Now, moving to the point of the components of the cost of illness. Okay, starting with the treatment cost, we use the term. We use the term direct medical cost here. Okay, another term it may call the treatment cost. Another group we call the direct non-medical cost. Okay, this happens to the patient and caregivers. Okay, patient have to travel to the hospital. During that time, they have they may need to have a hotel. Okay, they may need some special device, including the caregiver time loss. Patient need people who accompany to the hospital or take care at home. Okay, this is the cost of time of the caregiver. Another part we call the indirect cost or the productivity cost. Okay, this is focused on the patient time loss during the treatment, covering even the premature death. And when we conduct the study, we have to concern that we have the study site here. Okay, we have study site here, but we have to concern that before coming to the study site to get the treatment, okay, the patient might have the treatment before coming here at the drugstore, at the traditional healer. Okay, we have to concern, we have to include as well. Okay. And after acute care, we for some disease, we need to provide the intended care, long-term care until at the end, like a complete recovery or death. So we have to concern the pathway like this, and then the component mentioned in the previous slide, the cover the pathway like this. Okay, not only in the study site. Okay, these are similar to the previous slide that talk about when we calculate the cost. So the total cost is quantity multiplied by the unit cost. Okay, this just provide the example of the unit cost by type: OPD, IPD, medication, test. Okay, we have to include the component, the quantity of each component, and we need the unit cost of each component. Okay, and for the direct medical cost, normally we know the how much that patient pay for that one. It's straightforward to get the number. Okay, and this is the way to calculate the time cost of the caregiver. Okay, we measure the number of time lost in terms of days or hours, okay, and multiply by the unit cost. It can be the reference like an average income of the country, okay, or average earning per day. But in some study, they use the actual number. That means they interview one by one. Okay. But in this case, if we use reference, we don't ask how much they lost. We just ask how many they lost, and we use the reference per day to multiply the number of days here. So it's up to the study design. And for mortality cost, for the patient, it's similar formula to the caregiver time. This is more complicated for the mortality cost. Okay. We have to estimate the time loss of each one. Okay, and we use the GDP per capita in the future. Okay, and in the formula that we have to discount and sum up. Okay, same as I explained earlier. But this is an example to show the detail that okay, like a patient who died at age 56 in the year 2019. Okay, if this person doesn't die, okay, they stay until the retire age, and each year get the income. Okay, so we have to estimate the future income by using the per capita GDP. Okay, and this is the forecast GDP in the future. Okay, forecast vision future by 5% increase. And in each one, we cannot sum all of this to be the total cost of this person, okay, because this is the cost in the different years. Okay. In economics, they have the different value. We cannot simply add up. So we have to discount. Okay, this is in the year 2020. When we discount this number, is the value in the year 2019. Okay. Each one we discount, and then we can add up to be the total mortality cost of this person. Okay, this is the method to calculate the mortality cost. Okay, as I mentioned that when we calculate the cost of the illness, yeah, we need the unit cost of the services. Okay, a little bit to give the overview of the idea that when we would like to know the cost per OPD visit, cost per patient days, cost per lab test, cost per drug dispensing, something like this. Okay, we have to calculate the unit cost of medical service in the hospital. Okay, this is the overview of the concept of the method. Okay, we have to classify. This is the we call the standard costing method. Okay, we classify into the cost center and calculate the direct cost of each cost center, and we calculate the indirect cost of the absorbing cost center. This is the cost center provide the service to the patient. So the term in economics we call the absorbing cost center. And for the supporting administration like this, that we call the supporting cost center. We call the transient cost center. Okay. We allocate to the absorbing, we call the indirect cost allocation, and then full cost and unit cost. Okay, just overview of the brief of the method for the unit cost analysis of the service. Okay. Then the cost of the public health intervention, like vaccination, also part of the public health intervention or healthcare intervention. Okay. The definition is the economic or financial valuation of the resources used for the program. Okay, and we convert into the cost, and we also measure the quantity of the output. Then, in addition to know the total cost of the program, we also calculate the unit cost of the output of the program as well. For example, we have the screening program for the COVID-19. Okay, we calculate the total cost of the whole program. And we also calculate the cost per case who receive the test. Okay. And in addition to this, we may calculate the cost per case detected or the cost per positive case as well. Okay, that's an output or outcome of the program. This is the definition of the program. Okay. This shows you that when we consider the cost of the program, we have to consider that there are two partner, two stakeholders. The basic one is the provider and the service recipients or receiver, like people who get the vaccine. Okay, here, this is who provide the vaccine. Okay, and in the big program, we can classify into the health sector provider, non-health sector provider, okay. And in each one, okay, we can classify the unit into the supporting, into the service providing, okay. And at the activity level, we classify into the supporting activity and service delivery activity, okay. And all of activities, we can classify the cost. As I mentioned that we classify into investment cost and operational cost, okay. And the cost of this can be composed of the labor cost, material cost, and capital cost, okay. And when we can calculate the cost of the program, we have to define what are economic costs, what are financial costs, what are incremental, what are full costs. You say that we have to concern and make it clear in the program. And this is specific to the vaccine. So I give more specific to the vaccine, an example. Okay. For the vaccine, Ministry of Public Health is the main provider. Okay. But sometimes, like for for the vaccine, HPV vaccine, okay, we provide at the school. Okay. Even the COVID-19, when we provide the student right now, we go to the school and provide the vaccine at school. That means the school participate the program as well. And for the public health, we have the like a division of VPD or the EPI program as the supporting. Okay, and hospital health center is a provider. And even at the hospital, we have the administration, we have the vaccine delivery. You see, because in actual practice, okay, this unit also need the requirement of the support from the administration, okay, to support the activity to provide the vaccine. Okay? And in more detail of the activities related to the vaccination activity, we can classify into like a social mobilization and the actual service delivery to give the injection. Okay, that's similar to the previous slide. Okay, but we focus on the AEFI. Okay, adverse event following immunization. Okay, that's common for the vaccination. In up to the level of seriousness. Okay, we have to include, if we would like to cover the broader perspective, to cover the social perspective. So we cover both cost of provider and receiver here. And when the vaccine had the consequences and the side effect, okay, this are like a cost of illness as well, because this is the one type of illness, okay, but illness after getting the vaccine. So we have to calculate the cost in similar method to the cost of illness study, okay, to include as part of the vaccine program. Yeah. I have few more slides to finish. Okay. Okay, this is the just overview to cover when I mentioned about the economic variation. Okay. The concept of economic variation is to compare, okay, the alternative, both cost and consequences. Okay, when we have choice of intervention, okay, A and B, we have cost, we have consequence or outcome. Okay, both are different, so we have to combine result here. Okay, when we consider to choose A or B here. Okay, this slide just to emphasize again that, okay, in the equation we have the CEA, cost effectiveness, we have the cost utility, we have the cost benefit. Okay. And for the costing of the program, of the vaccine program, not just only for the cost of the program, but the cost of illness of the AFI and cost of illness for the unimmunized as well. Okay. To emphasize that when we talk about the cost of the program, it's not just cost of providing the program, okay, but include this and this as well into the cost of the program. Okay, I think that's it. Sorry for using more time. Dr. Hafidas, that's now your turn.
Okay, thank you very much, Professor Arthur, for the lecture. I hope many of the participants enjoyed the information and knowledge shared as much as I did. A note from me, it is interesting to find out that our countries, Indonesia and Thailand, are within the same GDP growth category for this year's second quarter, showing a positive trend despite the relatively low vaccine coverage still. It's definitely a great news considering the tremendous economic impacts that COVID-19 has caused in the year before. It's a good sign that we are economically healing. Even European countries you've shown before, which are mostly richer and more advanced than us, perform not even better. Okay, I can see from the list of participants, we have a number of students attending this lecture. For postgraduate students, I believe that many have been exposed to health economics, but for undergraduate students, this field may be a new stuff and it's a bit complex. We hope you find it interesting though. Well, okay, the next session will be Q&A. I will allocate approximately 15 minutes for this. And I'm anticipating to find some question in the chat box. Let me check. Yeah, we got 3 questions on the chat box. The first one is from Lely Tripangesti. She asked, how can we measure daily or COLI? Can we use COLI and daily for drug effectiveness review? That's the first question, Professor.
Okay. So the the daily and quality are the measure when we conduct the cost utility analysis or CUA. Okay. At the moment, it's acceptable to use either quality and daily, but you know, the way to get the quality and daily is quite different. For the quality, normally we measure from the patients, and for the daily, it's from the expert opinion. Okay, quality is more acceptable, and if possible, we use the quality. But if it's not available, you may refer to the daily. It also accept. That's my question, my answer.
Okay, thank you, Professor Arthur. To my understanding, quality is highly subjective. So I think there has been a debate on whether it is appropriate to account for calling for any, drug effectiveness review. How do you recount about that?
You know that if you measure the outcomes in terms of clinical outcomes, okay, you have to measure the cost per case avoided. Like if you prevent the disease, one case, how much you pay, okay, or if you prevent the death, one case, how much you pay for that one, okay. That's based on the clinical outcomes. We call the cost effectiveness analysis. Okay, it's acceptable to conduct that one. But in terms of the public health management, when we have to compare across the illness or across or type of interventions, okay, to allocate the budget to make decision to choose one. Okay, one case that we can prevent of the different disease, okay, it cannot be compared to make decision. Okay, then we convert everything into the quality adjusted life year. Okay, that means all kind of illness, okay, convert into the same unit that we call quality adjusted life year. So in this case, we can compare and make decision across the illness, across the intervention. Okay, that's why at the public health level, the highest making a decision process, okay, they just consider the CUA in terms of the quality adjusted life year that each intervention can produce for any kind of illness or health problem. Okay, how much that we have to use for per quality gains. Okay.
Okay, thank you very much for the explanation. If anyone wishes to ask a question directly to Prof. Arthur, please raise your hand. Well, I can't see a hand icon yet. Okay, so let's proceed with the next question. It's from Mutmaina. She said, thank you for the great talk, Professor Arthur. I'm just wondering if you are to make a cost analysis of COVID's impact, what time horizon is best to use given the dynamic nature of COVID-19 with recurring waves or outbreaks?
Because the COVID-19 is very dynamic. It change, the situation change every day. Okay, so the study design is up to the condition. Okay, you can design for any time period based on feasibility of your study, but you have to make it very clear and emphasize when you make a report that okay, the result of costing that you study and present the result, it come from when, okay, the time period of the study and including the condition or the context of that time. And when people would like to compare and consider how serious, okay, they have to consider the time period of and also the context of that time as well, and also like a epidemiological status as well. Okay, we cannot just simply compare two figures together and say which one is better. That's my idea.
Okay, so you think that for such infectious disease with high, dynamics, the shorter the time horizon is, the better for any cost analysis.
If related to the approaches, okay, COVID-19 is the acute. Okay, normally you should conduct what we call the incident-based approach. Okay, yeah. That means you have to follow, and then you present the cost per episode. Okay, that's the first point when you decide the cost of unit. For the acute one, it should be the prevalence incident-based approach to count the cost per episode. And then when you decide the period of the study, Okay, like you collect the data 3 months, 6 months, 1 year. Okay, that can have some effect because when you consider some kind of resources that the fixed cost is a fixed cost, that means the cost per month is the same. But in the period that you collect the data in a high season, it so many patients, so the number of patients is high number, so the unit cost is lower than the period of the less number of the patient. That has some effect on the number of output as well. So in this case, normally, okay, we consider the whole years to avoid what we call the seasonal variation. Okay, that's the general guideline for the whole year. And again, when you calculate and present, you have to say that you collect the data for how long and what year. Okay, 2 things: how long and what year. Okay, 6 months, 7 months, in what year. Okay, that you have to present.
Okay, yeah, thanks very much, Professor Arthur. The next question is from Dilma. She's asking, so she thinks with many kinds of COVID-19 vaccines available at this moment, which one do you think is most cost effective?
I don't think that anyone can give the answer. You know, even right now, the efficacy is still controversy. Right? Efficacy of each vaccine in different countries, in different contexts. Okay, and vaccine is still in the process of the improvement as well. So, okay, it's really hard. That in general of the nature of the vaccine, okay, it's not efficacy is not quite clear right now. And in addition to that, in the detail of the efficacy, okay, it's also different when we talk about the efficacy. It to prevent the hospitalization, to prevent death, to prevent complication, something like this. Okay, it's different kind of efficacy as well. So anyway, you see that I present one paper about comparing the vaccine. That's right. We can do. Okay, we can do, but we have to keep in mind that there are a lot of assumptions. Okay, you don't know exactly, but you assume, you estimate especially the efficacy, and you put in the model, and you see that okay, based on this condition, okay, this is the result. Okay, not the final answer, but based on this condition, this is the result. Just provide some guidelines. Okay, yeah. Not the final answer.
Okay, it's still ongoing, and we are looking forward for the next research on this topic for the comparison for vaccine effectiveness. Okay, we still have some more questions. Are you okay with this, Professor Arthur? I think we
yes, no problem.
Yeah, okay. Still 4 more questions. The next one is for Maria Vishnu. Thank you for the lecture, Professor Arthur. Could you please explain more about when to use incremental cost or total cost in CAA in a 1-year drug use evaluation? So if you could elaborate.
Sorry, say again, what to use what?
Yeah, she wishes that you can elaborate more on how or when to use the incremental cost or total cost.
Okay. Sorry. Okay.
Yeah, in 1-year drug use evaluation.
Okay. So it's up to the context of the study. For example, if we have had for the EPI, I think vaccine is good example. For the EPI program, okay, like in Thailand, we already have 10 antigen, or just simply say that 10 vaccines. Okay, and when we had the new vaccine into the program, Okay, in this case, we just concern the incremental part of the new vaccine. Okay, because we already have the program, we already have the cost for the program. Okay, and when we add, okay, even we don't add this vaccine, we cannot reduce the cost that happened for the 10 vaccine. Okay, we cannot reduce. So that means when we add new vaccine, we just consider the additional part cost of the new vaccine, only that. Okay. But if you would like to start the, like for example, for the COVID-19, you would like to consider the combination of the many interventions to tackle the COVID-19. Okay, you start right now. Okay, okay. In this case, you should, because in the short time, okay, when you add, you modify the program, so you can modify the activity, the cost. So in this case, it's better to use the full cost because you know the program can be adjusted in the short time and can share the resources for the others interventions. Yeah.
Yeah, it's quite technical question. I hope Maria is happy with the answer. If not, perhaps she can contact you for more.
Yes. Okay.
For more explanation. Yeah. Okay. The next question is for Dr. Suyatmi. Thank you for sharing very interesting knowledge today. My question may be out of the research context, but I just want to know whether the Thai government also implement a budget for rehabilitation from long COVID impact besides the rehabilitation for the economic impact. We happy to hear the situation in your country. Thank you. So it's about whether the Thai government implement a budget for long COVID rehabilitation.
Sure that we have to solve this serious problem. So I think we try every way to solve the COVID-19 problem. Okay, but in more detail, in really detail, I don't know how much detail that you would like to get the answer. So I don't know exactly the proportion of the budget for each part. Okay, but principally, okay, we try every way to solve the problem. I don't know. I'm not sure. The rehabilitation mean the medical rehabilitation or in the general.
Yeah, I guess that kind of thing. I mean, because in our country, to my knowledge, the impact of the long COVID is not yet funded by our government. I mean, the funding is prioritized towards the acute and active cases, not for the long COVID.
In medical aspect, that right?
Yeah.
That means medical rehabilitation for the people who get the infection. Okay. I think for Thailand that gonna be included into the routine system. Okay, because the rehabilitation, medical rehabilitation included in the part of the health system or the service system already. Okay, so they can go to the hospital and get the treatment and use the health insurance. Okay, I don't think that there is an additional in general additional budget in general for this one, but because already included in the routine services. If you mean the medical rehabilitation of the COVID patients in the long future.
Okay. Yeah.
Yes.
Thank you. I think we still have a couple more questions. How about this one is from Dr. Rati Devi. Yeah. How about long COVID, Professor? Is there any study that focusing on the cost analysis related to long COVID cases, especially in Thailand?
For the
is there any study focusing on the cost analysis related to long COVID cases in Thailand?
To the long COVID. Sorry.
Yeah.
What that mean?
Yes. She's wondering if in Thailand there is a study focusing in the cost analysis related to the impact of the long COVID at the moment. Is there any study about that?
Of the long COVID?
Yeah, long COVID. Because I think the number is increasing for the long-term impact of COVID-19.
You mean the long-term impact of the COVID infection?
Yeah, yeah.
I have no idea about that one at the moment. It would be later, okay. But right now, we just have the project to estimate the cost of the acute care of the COVID-19 treatment. For the long term, because we have to wait as well as to see what is the consequence of the infection. So I don't think that we have had at the moment for effect of the long term of the COVID. We have to wait.
So there's a gap knowledge on that. It's potential to be researched further. Yeah. Okay. The last question, I think it's from Citi. Thank you, Professor. I'm sorry, maybe out of topic. I'm wondering about the budget impact analysis for COVID-19 vaccination program. Is this feasible to do or not?
Yes, basically we conduct a budget impact when we conduct the cost of the program. Okay, after we know the cost of the program, we have to estimate the budget impact. That cost to the costing, but that is not exactly the same costing result for the budget impact, because this is the guidelines for the policy decision making. Okay. We provide the costing study, we provide the cost effectiveness study, and we have to provide the budget impact, because finally, after we know that the intervention of the vaccine is cost effective, okay, the government have to consider if they have the budget or not. Okay, even it's cost effective, but if it consume a lot of require a lot of the budget, it's beyond the availability of the budget, so we cannot do that one. Okay, that means the final answer is based on the budget impact, because it related to the money that the government have to implement or not. Okay.
Okay. Yeah. Thank you, Professor Arthur. Anyone for any more questions? I'm sorry for the back sound for the prayer calling. Okay, I think that was the last question, and I think time is up for the Q&A session. I hope everyone is happy with the answer given by Professor Arthur. So, as we are approaching the end of this lecture, may I remind you all that we have put the link for the electronic certificate in the chat column. If you have not filled in one, please do so. And as we promised before, we have picked up 3 participants to get our little gift. It's little, but still decent, I think. So, congratulations to Maria Wisnu, Suyatmi. Oh, we got the display here. We got the slide here. Congratulations to active participant Maria Wisnu, Suyatmi, Mutmainah, Dilma, and Lely. Please confirm to the number on the screen so that you can claim the gift. And before passing the control back on to Dr. Rateh as the MC, we of course are not forgetting our high appreciation to Professor Arthur. Thank you very much for your time and sharing knowledge on health economics with us. It is well structured and quite detailed actually for such an introduction. So it's definitely useful for us, especially for those interested in health economics field. And we will email you an electronic certificate of appreciation shortly after this event. We hope that one day we can collaborate with you, Professor, for some pharmacoeconomic research. Okay, everyone. Yeah, we're looking forward. We're looking forward to it. Okay, everyone. Before closing off this session, we are again wanting to thank you all for staying with us. We hope you can gain some new insights into health economics and have a wider perspective from now on when looking at the disease and intervention, how the impact can be actually quantified to measure disease burden and treatment effectiveness, as well as to mitigate loss financially. Also, our apology for any inconvenience you may have encountered during this event. We hope we can meet again in other webinars with different topics. Have a great weekend, everyone. Stay safe, stay healthy, and bye from me. And now I'm giving the control back to my colleague, Dr. Rate, please.
Yes, of course. Thank you, Dr. Nur Hafida. And thank you very much for Professor Arthur. Very nice lecture and giving us about health economic impact. It's very useful and very informative. And thank you very much. And before we ended this meeting, can we please take a picture together with the participant? Ya, mohon teman-teman para peserta untuk menghidupkan kameranya. Please turn on your camera. Mungkin bisa dibantu untuk capture. Oke. 1, 2, 3. Okay, it's the first. And the second page. Yes. Okay, and the third page. And the fourth page. 5, and the final page. Okay. Thank you, everybody who joined this guest lecture, and thank you very much, Professor Artan, for your information. Your guest lecture is very interesting and very informative. And to all the participants, I hope you enjoy this weekend and stay safe and keep healthy. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Bye-bye.
Bye-bye.
Assalamualaikum warahmatullahi wabarakatuh.
Thank you, everyone. Have a great weekend.
Thank you, Ajahn.